Welcome to the Agency for Healthcare Research and Quality's national webinar on empowering patients to change behavior using digital healthcare tools. Again, people are still logging in, but like I said, I want to go ahead and get us started. My name is Kevin Chaney, and it is my pleasure to moderate today's webinar. I currently serve as a Senior Advisor for Dissemination and Innovation for AHRQ's, the Agency for Healthcare Research and Quality, or also known as AHRQ, our Digital Healthcare Research Program, or also call ourselves DHR, which is part of the Center of Evidence and Practice Improvement. DHR's mission is producing, disseminating evidence about how the evolving digital healthcare ecosystem can best advance the quality, safety, and effectiveness of healthcare. And to fill this mission, this program funds research that yields actionable findings around which digital healthcare technologies can improve care for our key stakeholders, patients and caregivers, clinicians, and health systems. We will discuss 3 of these exciting research projects during today's webinar. So here's the agenda for today's webinar. Please note that we are recording the webinar and that the recording and slides will be made available on the DHR website in a few weeks, and you'll be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters, including Dr. Mei Leung and Dr. David Dorr. You'll see, and you might have seen also on the announcements we sent out, we were hoping to have Dr. Antoinette Schoenthaler with us, but she unfortunately had a last-minute emergency and will not be able to join us today. But I would still encourage you to visit digital.arc.gov to learn more about Dr. Schoenthaler's project, where you can also see some of the more recent publications that her and her team have put out, in addition to today's presenters, Dr. Mei Leung and, again, Dr. David Dorr. This webinar is accredited by Affinity CE. If you're interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of today's presentations. And it will be also emailed to you after this webinar. For the purposes of accreditation, let me just note that AHRQ, our contractor supporting us, SD Solutions, and Affinity CE have no financial interests to disclose, and that Drs. Leung and Dr. Dorr also have no relevant financial interests to disclose. Please note that no commercial support was received for the development of this learning activity. So, how to submit a question. Just a brief note, we have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the question and answer or Q&A panel that's located in the right of the PowerPoint slides. Please include the presenter's name or their presentation order number, first, second, or third, with your question. It can help us kind of tease out who you're directing your questions for. And as a reminder, participants are in listen-only mode, so to ask a question, you need to use the Q&A panel. So today's learning objectives for today's webinar. So by the end of this presentation, you should be able to discuss how an interactive family-centered digital health promotion tool can address childhood obesity, and then explain how using a standards-based CDS tool for blood pressure management has the potential to improve outcomes by empowering and engaging patients. And now it's my pleasure to introduce our first presenter, Dr. Mei Leung. Dr. Leung is an associate professor and chair of the Division of Nutrition Interventions, Communication and Behavior Change at the Friedman School of Nutrition Science and Policy at Tufts University. Her current research focuses on the design and evaluation of innovative interdisciplinary health communication and community-based interventions to promote healthy eating and physical activity in populations who are underserved and at greater risk for chronic diseases. Her work is also grounded in community-based participatory research methods, where she engages and empowers communities to have an equal partnership throughout all phases of research. And with that, we'll hand this over to Mei, and you can begin.
Thank you so much, Kevin. It's a pleasure to be here. Today, I'm going to be presenting results of a usability testing study of this interactive family-centered mHealth tool to reduce childhood obesity risk in urban youth. Okay. So this work highlights the importance of incorporating user-centered design approaches during the design and development stage of a digital health tool, because this can inform more efficient and effective delivery and use of culturally relevant healthcare resources in the clinic setting. So as we all may know already that childhood obesity is a serious clinical and public health issue, and we need to develop engaging interventions to be able to capture the attention of youth as they're living in a media-saturated environment. And we believe that multimodal narratives in the form of comics, so storylines being conveyed in a combination of text and imagery, can be an appealing format to deliver health messages, and particularly with youth. Also, the pervasiveness of technology highlights potential opportunities to be able to engage with culturally diverse and also hard to reach populations. In addition to that, we also have become aware that culturally relevant and meaningful health promoting tools are limited for clinic based healthcare providers. And so, with that in mind, we developed a digital comic tool titled Game On. And I am focusing on the child components of this tool. There is a parent piece, and I can talk about that briefly later on. But the information that I'm presenting and the results today is really focused on the child piece, which is this digital comic tool. And this tool is a 12-chapter web-based interactive nutrition comic that's informed by the social cognitive theory and also the health belief model. And it has a lot of different components in addition to the comic itself that has these embedded health messages, but it also has a weekly goal setting and assessment component where children are able to select goals on a weekly basis and try to work on them throughout the intervention period. There are also trivia questions and character profiles and badges that the children can earn, in addition to reminder messages, all reinforcing the health promoting messages that are within the comic. And this tool is specifically designed for Black, African American, and Latino children between the ages of 9 and 12, and really more specifically, pre-adolescent stage of development. So we wanted to test the usability of this family-centered digital health tool with our intended populations to build enhanced acceptability, engagement, and cultural relevance. And so I just want to make sure we're all on the same page in terms of what usability testing is. And this is when your intended users will interact with your tool or your product, and we're able to evaluate the product to be able to identify any usability issues that arise, and also to see if users actually are able to complete tasks that are asked of them within the tool. And ultimately, we want to be able to identify changes that we should be making to improve the overall experience, to improve the overall user experience of this tool. So our participants included, as I said, Latino and Black African American children residing in low-income neighborhoods in New York City, along with their parent or guardian. And data collection occurred between December 2023 and also February 2024. So the mean age of our children was 10. There are slightly more males and females who participated in this usability testing study. As I said, the children had to identify as Latino and or Black African American. And the family actually reported a household income of, well, nearly 60% of the families reported a household income of less than $25,000, and 75% reported receiving SNAP benefits. So within this study, there are 2 rounds of usability testing, and this was all done remotely. In each round, there was this modified think aloud approach that we used while the child interacted with the tool. And the think aloud approach is a widely used method for usability testing of a software, of websites, and also of apps during the development process. And the basic principle of this think aloud protocol is that users are asked to, well, complete a set of actions or tasks that are asked within the tool, to navigate throughout the tool. And the participants are asked to constantly verbalize their thoughts while working through the tool. And this allows us to identify any issues that may arise, any confusion, anything that may be unexpected for the users. But we modified this approach for our population because the original Think Aloud protocol can be a bit too broad and maybe a bit too abstract for children because it's usually used for adults. And so we use prompts, we use a little bit more directive questioning to help the children verbalize their thoughts as they engage with this web-based tool. So field notes were taken to document participants' comments and behaviors and document how they actually performed on certain tasks that we asked of them. And then the participants completed a 12-item questionnaire to be able to assess their perceived usability, acceptability, and satisfaction of the tool. So a content analysis was conducted with the qualitative data where comments were coded as positive, negative, and general, and they were grouped by theme. And the quantitative usability scores were compared between round 1 and round 2 because modifications were made to the tool after our round 1 testing, and then we retested the updated or refined tool in round 2. So there are a lot of numbers on this table to the right, but what I really wanted to point out is that there was a total of 90 comments that were coded within both round 1 and round 2, and 5 usability themes emerged from these comments, which included website appearance, the comic content, so how the information was delivered through the comic tool, the storyline, special effects, as we did have special effects to enhance the engagement of the tool, such as sound effects, audio dialogue, and also animations, and navigation. So this was in terms of the ways that the user navigated throughout this tool to be able to complete specific tasks. And so overall, the feedback was positive. There were 100% comments, positive comments in both round 1 and round 2 about the website appearance and the storyline. So the children liked the color scheme, design, and layout of this tool. They also found the story interesting and they found the characters relatable. And the majority of their comments were also positive, related to comic content, special effects, and navigation. However, they did have some requests, and some of those common requests were that they want to see more color in the comic because this comic was specifically black and white, and we used color to really enhance specific messaging around promoting positive dietary behaviors. Otherwise, the comic was predominantly black and white. The children also wanted to see more special effects. They wanted to hear more audio dialogue from the characters. They wanted more pop-ups and animations because they thought that would make the comic more engaging. And for the children who conducted the usability testing on smartphones, which majority of them did, they wanted to see a larger font and larger navigation buttons because on the smartphone, the screen's a little bit smaller and they had a little difficulty reading the actual comic on that size of device. So we also made some specific modifications based on observing how the children engaged with the initial version of the tool in round 1. And so these were modifications that we made between round 1 and round 2. So the first modification was removing, well, a specific button from the navigation bar. So what we found in round 1, we had this double arrow navigation button within the bar on the bottom of the tool. And what we found in round 1 that 50% of the children were accidentally hitting that button, which then resulted for them skipping all the way to the end of the chapter. And we didn't want them doing that accidentally. We wanted them reading every page of each chapter. And so we ended up removing this navigation bar for round 2. And of course, the issues of them accidentally skipping to the end of the comic or end of the chapter was resolved. So, okay. We also tested the wording of the goals. As you may recall, we have a weekly goal setting and assessment component that after the child reads the chapter that was issued for that week, they then get to select a goal to work on for that week. And what we found out, we thought we would include examples of fruits or examples of vegetables within the goals that the children can choose from. But what we found out is that half of the children were actually choosing goals based on the specific food examples that we provided, rather than focusing on the actual goal itself, such as eating fruit at breakfast every day for that week. And so we ended up removing all the examples of fruits and vegetables and just making the goal a bit broader, so to speak, so it would really just highlight the actual behavior that we wanted them to focus on. The comic was drawn, ideally viewed in a landscape version. But we discovered in round one that children actually didn't realize they could flip their phones. And so most of them are reading it in portrait view. And so we included this prompt uh, that they could view the comic in landscape. In fact, it would be better viewed in a landscape view. In fact, actually, that notice or that pop-up message would not disappear until the child flipped the phone in the landscape version. And this was also in a way to hopefully enhance engagement of the tool itself. So during the initial round of testing, we found out that that some of our child participants had actually never read comics, and so they didn't know the order of the panels to read, which would then interrupt their immersion into the story and engagement of the tool. So we included this How to Read Comics pop-up guide to provide a visual demonstration of how the comic should be read, and also what the different speech bubbles meant. So as I mentioned earlier on, we also collected some quantitative data around, through a usability survey, and we found that the scores were high in both rounds, which indicated high usability and satisfaction of the tool. So that was positive and promising. What I want to highlight here is that this study is one aim of a multi-aim R01, and the findings of this usability study informed refinement and enhancement of the tool with the goal to increase its cultural relevance and usefulness, and thus therefore increase its potential engagement. And so we are now testing this tool, which is this 12-chapter comic tool, in a full-scale RCT with 200 parent-child dyads. And we're recruiting through community-based clinics. And this is with the ultimate goal to inform more efficient and effective delivery and use of culturally relevant healthcare resources in a clinic setting for populations who are at risk of childhood obesity. And so we also have, in addition to AIM-3, where we're evaluating the effectiveness of this tool with this full-scale RCT, we have an implementation aim as well, where we really want to explore the contextual factors at the clinic provider and also family level that influence potential future implementation of this adapted tool. Okay, so I wanted to share some lessons that we learned through this usability study, and actually also our AIM-1, which was also another part of our formative research process. Well, some of the things that worked well was that we were able to re-engage some participants who were part of a previous phase of this study. And these were families who obviously we already had a relationship with. And so we already built rapport and trust with them. And therefore, because of that, the communication was smoother and scheduling was much easier. We also were able to use snowball sampling with these participants. And so we were able to ask them in terms of if they had any friends that they could recommend to our study. And therefore, re-engaging actually these participants really helped the efficiency of recruitment and data collection of this aim. Another key factor in the successful data collection of this aim was that we offered flexible scheduling for our families. And since the pandemic, as many of you I'm sure are aware, is that many families of our intended population have grown comfortable with virtual meetings. And we found actually in our AIM-1 that most people prefer to meet over Zoom, because AIM-1, we gave them the option to either meet remotely or in person. And majority of our participants wanted to meet via Zoom. And this format, the remote format, obviously eliminated barriers like travel time, and which therefore made participation a lot more convenient. We also made sure to offer appointments after 5 p.m. during the weekdays, and we offered weekend appointments as well. So we sometimes we're doing data collection at 9 p.m. at night, or of course on Saturdays and Sundays, really to accommodate the schedules of very busy caregivers and children. So because of re-engaging our participants and also this flexible scheduling, we were able to complete all of our sessions in a 3-month window, even though data collection took place during the height of holiday season in December, and also at the right after the holiday season, which is also a busy time as well. So of course, there are some things that were challenging. And so while meeting remotely did help to remove some barriers to participation, it was also a challenge to conduct usability testing remotely, because this is often conducted in person. So we had to adapt our protocols for remote data collection while also maintaining a strong, robust methodology. And so our sessions were conducted via Zoom, where the participants shared their screens so we could observe how they navigated the website. And in fact, I will say in many ways, actually, them being able to share their screen helped us identify navigational issues, I think, more easily than, in some ways, than conducting this in person. But because of this, we needed to build in time during the sessions for potential tech support. And this did happen quite often, and mainly in terms of understanding how to share their screens. That was kind of one of the biggest challenges that our participants had. So while we conducted these sessions on Zoom, and it allowed us to capture the video of the users navigating the website, which we could then go back and review for further analysis, we may have missed some nonverbal cues such as body language and eye movement, which we otherwise actually could have identified during in-person usability testing. So this could have added to our understanding of the user's experience of our tool. So some things that we're doing now based on previous experience, well, we are continuing to leverage our relationships with our community partner clinics to support recruitment. We are having healthcare providers discuss the study with families and to share recruitment flyers, and this helps build trust and credibility of our study. Also, all enrollment and all data collection is being conducted for AIM-3, by the way, which is our full-scale RCT. All of the enrollment for this RCT is conducted remotely over Zoom, and we have now prepared or curated tutorials that are available in both English and Spanish for different device types, because they could engage with the tool on a computer or a laptop or a tablet or a smartphone. So we specifically have designed and created tutorials in terms of how to utilize Zoom across all these different device types. And these are ready to send to any family who may indicate that they need some support with utilizing Zoom. Also, in response to technical issues that we encountered in our usability testing and also in our AIM-1, we've built in different internal checkpoints to ensure that the tool is functioning properly throughout the study. So for example, we're confirming that click tracking is working because we have some usage measures that we are collecting in our randomized control trial. But we're confirming that click tracking is working during the enrollment appointment on Zoom when our participants are creating their accounts. We also are reaching out and doing informal check-ins with our families to make sure everything is working okay. And during one of our informal check-ins, we found out that one dyad has completely lost access to internet since enrollment. And so we haven't removed them from the study. They're still a part of the study, and we've told them that they can continue participation once they regain internet access. So had we not followed up with them, we perhaps would have just, they likely would have just been a dropout. And so these informal check-ins are helping us stay connected with our participants. So AIM-3, which I'm not going to go into detail about this because we don't have time, but it is a study participation is 15 months for our subjects. And this includes 4 data collection time points. And so we are well aware that there tends to be a high dropout rate right now for longer term studies. And we've increased the total incentive amount incrementally to hopefully increase engagement and retention in our 15-month study. And also, we are adding additional touch points through data between data collection time points to build and also maintain rapport, such as actually digital birthday cards that we're sending to our child participants and also our parent participants as well. These small gestures really can go a long way to keeping families engaged and making them feel connected to the study team. We also assign a single research team member to each parent-child dyad. So there's consistency in terms of who they connect with at each data collection time point to further build, rapport and connection within the study. So that is it, what I wanted to share today. But before I wrap things up, I just wanted to acknowledge AHRQ, who has funded this study. Also, my community collaborator, Children's Aid, where we're engaging with the healthcare providers and administrators there. And our participants are coming from this child-focused nonprofit. And of course, my incredible research team who have just been such a key part of this research. So thank you very much.
All right, thank you so much, Dr. Leung. And right there for folks is Dr. Leung's email. But just want to say thank you. And again, if you have any questions for Dr. Leung, please feel free to put them in the Q&A panel. And that way she or whoever else, we can answer them throughout today's presentation. And I'll have some more questions for Mei at the end of Dr. Dorr's presentation. With that being said here, let me go ahead and move it over. There we go. So I'd like to introduce our final presenter, Dr. David Dorr. And Dr. Dorr is a professor and vice chair in medical informatics and clinical epidemiology, as well as internal medicine and geriatrics. He's also the chief research information officer at Oregon Health and Science University. Dr. Dorr focuses on improving capabilities and use of innovations to manage data, information, and knowledge and research, and in translating it to healthcare. His interests include complex care management, especially for older adults and other at-risk populations, coordination of care, collaborative care, chronic disease management, quality, and the requirements of clinical information systems to support these areas, which, as we all know, is very critical. And so with that, I'm going to hand this over to Dr. Dorr.
Great. I'm very excited to be here, and I really appreciate the invitation from you all and for AHRQ for funding actually 2 grants related to this, initially a U18, and I'll talk about where we are with an R18 that is focused on a trial of a tool. And of course, I don't do this by myself. So I have a co-PI, Rochelle Koopman, who's at the University of Missouri, and a site PI, Will Martinez, as well as Dr. Shannon Canfield, Victoria Schaefer, and Abby Robecki, and our local folks, Emma Montgomery, Leanne Michaels, Ashley Herrick, and several others. So it's a team effort, and it's been an incredible amount of fun to do. So really, our goal for the study is to understand how we could create something that was aimed at people who have high blood pressure directly to offer them clinical decision support in order to improve outcomes for some very specific needs. As you may know, clinically, hypertension is silent. So having high blood pressure, you may not feel bad at all, but high blood pressures can be very worrisome to people because people know that they generate a risk for heart attack, stroke, kidney failure, cognitive dysfunction, like things like early onset of dementia, which means that people often get into a spot where they feel worried, and yet they're not bothered day to day. And so figuring out how to encourage people to take action without having those worries grow is incredibly important, and is an area where cognitive science can really help us, as well as thoughtfully created clinical decision support tools. Our tool and approach to this is called the collaboration-oriented approach to controlling high blood pressure. And largely, it's an open source Smart on Fire application. So it sits on your phone or on your computer, running in largely a web browser. And it connects to your electronic health record data, but also can connect to other devices for blood pressure. And has a lot of guidelines embedded in it. And the information is presented in such a way that it's trying to aim for the therapeutic index of taking action on your blood pressure, but not and reducing worry at the same time. So sort of avoiding the harms that can come, as well as improving outcomes. And so far, we've had a lot of positive results that I'll talk about, in part because this is a significant gap for care teams, and to some degree, there's a burden put on patients because we ask them to monitor their blood pressure at home very frequently anyhow, and yet the amount of time that people actually do that is limited. So our impact of this is really, we built this tool very carefully. It's open source, it's standard based, you can share it, it's interoperable in that it exchanges data back and forth, including back into the electronic health record systems in which it's implemented. And it's really empowering for patients because they're very much in control of this. They can communicate more readily, as you'll see, and they can really feel like they can take control of and learn to manage their blood pressure and ask for help when they need it. So why do we study blood pressure? Well, it's extraordinarily common. 46% of adults have high blood pressure. It's in certain populations tend to have it more frequently. And about half of those, their blood pressure is still high enough to put them at substantial risk for heart attack and stroke, 140 over 90 for systolic and diastolic blood pressures, respectively. The high blood pressure is also a factor in about 500,000 deaths per year. And it can be addressed. We can actually provide ways to get tight control of blood pressure, both with medications, but also with a wide variety of changes to our daily activities, such as increased exercise, avoiding certain foods, weight loss, smoking, and alcohol avoidance or reduction. And so there is so much we can do both at home and in the clinic to manage this, but as you start to put on medications, especially, you can get increased adverse events. And the graph here shows the results of the SPRINT trial, which also told us that these benefits accrue even as you get into older age. So here, if you look partway down, you see age greater than or equal to 75 actually had a bit better outcome than people less than 75, showing that it's never too late to start to address this. The primary guideline recommendation we were focused on here was when you have suspected high blood pressure in the clinic, either a long-standing blood pressure that we think has gone up or a blood pressure that's never been controlled, when it's only measured in the clinic, sometimes it can be artificially high. Blood pressures can temporarily go up. We call the office-based one white coat hypertension because you're in there in the office and maybe stressed, and that raises your blood pressure. So there's a recommendation in the guidelines that's evidence-based to have patients monitor at home. And my experience using our EHR to do this is a screenshot from that EHR with all the information redacted, is that I'd assign this to people, I talk to them, we'd go through it, and then I would sort of write a prescription for it, and then they could enter the information a variety of different ways through their devices or manually into the system, and less than 20% of them were doing it. And when I wanted to review the information, it came in a very clunky fashion in many messages here that all look the same, because it also told me when they weren't measuring it. So most of these messages you see here have no information in them. And people were worried, right? They just didn't want to think about it. So we built this application in part using many of the techniques Mei just talked about to try and figure out ways to present the evidence about this, the need to measure your blood pressure and how to understand the blood pressures you're getting and when to worry and when not to worry. And so we built a tool that had many different components in it, a graph of what's normal according to their goal and what's high, lifestyle changes and goals, average, that's actually quite important when you're measuring at home. And then we worked iteratively to change the language over time. We also built so that people could understand and interact with it, asking patients and care teams for what was most appropriate. We also built it so that it was as seamless a workflow with the normal tools, the usual tools we use. So the trigger is that the physician says, hey, just like I did, I need home blood pressure monitoring. And instead of getting that list of messages about whether people are doing it or not, then that triggers a similar underlying EHR workflow, but it now connects to this application that we built that has all the components in it. And then the patient logs in through their patient portal to the app directly, and then can see all this information. They also can use Bluetooth connected devices, in our case, the Omron monitor, and then the blood pressures automatically can get synced, and then they can just look at the information display to get what's happening right now. There's some back-end interoperability. We used the Fast Healthcare Interoperable Resources because that's the interoperability standard. And we used something called CQF Ruler that AHRQ's CDS Connect helped sort of promote. And what that does is capture the guidelines in a structured format that then allows them to be modular and changed over time, which is quite important as guidelines change. So one of the hardest parts when we were doing this was actually thinking when you introduce a tool like this, you have to put some structure around it. And what we found when we worked with the clinics initially, they had all kinds of approaches to this. Sometimes they'd assign a pharmacist or a nurse to follow up. Sometimes they just waited to the next appointment and just saw if the patient did it or not. But because we wanted to also remind people about doing this to increase their likelihood of monitoring their blood pressure, so we had enough data to understand this, since less than 20% of people were actually monitoring their blood pressure at home, We really had to build a very careful and sort of overly detailed in some way workflow so that we wouldn't miss anything, we wouldn't wait too long, we wouldn't remind too soon. And our biggest change here, this is our study protocol for a randomized controlled trial, is that we ended up having to sort of define a monitoring block where we just like measure your blood pressures, and we try to get that done within a month. And then if they get 12 blood pressures earlier than that month, then we try and move them to this action block where we're really either the patient takes action, they set a goal for lifestyle change, changing their sleep or activity or diet, etc., or a care team action where the patient can communicate to the care team with all the information the care team needs about their experience in monitoring their blood pressure, that average, all the scores, whether they've had any problems or issues, and get action taken much more quickly. And then repeat this block because often blood pressure control is iterative, and we want to know, did that work? Is that enough? Do we have to change one or more of those actions over time? To really study this, though, we wanted to use cognitive science to lower what we call affective response to an area where it motivates but doesn't worry. So affective is sort of an emotional response, the affect of a person. And what we did with this is use some work by Dr. Koopman and others, also in an R18 from AHRQ, where a display with an average blood pressure of a certain kind and these sort of different levels of the blood pressure ranges that were appropriate for this person could be displayed. We also allowed, with a conversation between the care team and the patient, them to change these levels. So if you change the goal blood pressure to like 120/80, these ranges will change. And then the average will change as well. Dr. Schaefer, who's our cognitive scientist, helped do a series of studies where we had different displays. And we decided on the stoplight one where you get a yellow if it's above range, and you only get a red if it's really high and there's a potential risk for hypertension related problems, like a concern for a stroke. So which was a really interesting experience for me. There are many different versions of this. For the non-intervention patients, we still give them the application, but we just mainly put the safety recommendations in there. So if their blood pressure is really high or low, it will, or they have other potential side effects in their chart from blood pressure that'll warn them that they should talk to the clinic. It has their goal and it has their medications like in the other one, but it just doesn't have these other ones. So we want to see, is the first more effective than the second, or are they both pretty effective? Because sometimes the Hawthorne effect, just the observation of a study, tends to get people to do this. We also give them a blood pressure cup, which is useful. Most of the time in our study, to be honest, we've spent trying to understand how best to implement this, both from the patient and caregiver perspective, but also the clinic team. And we use the consolidated framework for implementation research, and we did that using a series of site visits. So we went to every clinic, we interviewed as many people as we can. That was Dr. Canfield and Dr. Koopman, along with our study team. And we basically asked them a series of questions about how they manage blood pressure now. Did they have any quality improvement initiatives? Who was involved in it? And then we sort of took our intervention in this model and we said, what's the core components we need to keep? What can we change? Both in the application itself, the programming it, but also the way we implement it. And we learned quite a bit from that process. We made many changes, and then we come back every month to talk to them. And that's part of this process where we're sort of encouraging them to continuously look at what they're doing involved. So we also designed the trial as highly pragmatic, and we use two tools for that I want you to know about. One is PRECI2, which is basically like a continuum of pragmatism versus sort of an efficiency type trial. That might be the usual trials that are everything's controlled. In pragmatic trials, we try and do everything in routine care, change as little as possible, so we know whether it will work in regular care and it can be sustained. So we rated ourselves on things like how flexible could they deliver it. So we said, they told us, well, we can generate all our patients with high blood pressures in the clinic in a bulk thing, and then we can put an order on. That's what we usually do. We made that possible for them. If they just wanted to refer patients directly by ordering in each individual visit, we help that to happen. And then we also said anyone can be involved as long as you in the clinic think that's appropriate. So a lot of flexibility. And then we did provide them with guidance and helpful components so that the patients could feel supported overall, but we really wanted them to own this process. For readiness, we really talked about, is this the readiness for pragmatic trials, which is a great study, readiness assessment for pragmatic trials, which is called RAPT, is this one on the right. And it's a similar scoring, but it has things like how acceptable is this to the providers? Does it align, or their care team and the patients? Does it align with their priorities? Is it important to them? Are there risks? And most of the changes we end up making, we're trying to get it more aligned, more focused on the workflows that they already had, and mitigating risk. We really worked hard on changing our approach to ensure that they felt confident that if a patient got a high blood pressure or had a problem, the tool would really promote contacting the clinic in an appropriate way and with the appropriate information. So here's some examples of what we asked, like what evidence do you need? How do you think the intervention will meet the needs of the individuals? What changes? How will the culture affect this? And then what are things like infrastructure changes that are needed? We ultimately ended up for the trial implementing in 3 different sites with 2 different EHRs, which took a very long time. Here at Oregon Health and Science University, we did the initial studies, so we already had it implement. But what we found very early on is there was a huge unmet need for this. So we had almost 2,000 patients referred into the study, some of which were coming 100 a week or more, which is quite a lot for this kind of study. It's a 6-month study with patients, and they have to go through these iterative cycles. They're asked to monitor their blood pressure and reminded quite a bit, including having surveys over time. Anyone is eligible to be in the study over 18. Children's blood pressure is a little different, so that's why adults only. But most of them were older. And here's what they wanted from us. They wanted the alerts to be appropriate and not overwhelming, because some of the messages were too many, which we changed over time. They really wanted the follow-up messaging to be clear to patients and done in a sort of a routine way. They wanted, to understand what motivated patients and what was happening with them. So we provide that on a monthly basis. We actually changed the programming to reduce data entry. We had manual entry at first, and we thought, well, we don't need to do that. And so we built a way to get that Bluetooth data into the system through an API connection. How we set and adjusted blood pressure goals, we changed so they could do it right away and then come back anytime to change it as needed. And then a lot of workflow changes to make it easier. The centrality of pharmacists in some clinic, for instance, is a good example. They really told us about all the problems they had, and then we worked really hard to build the tool to address that. So for a user experience, I would say very simply, the digital gaps still exist for certain populations. People really struggle sometimes to connect and figure out how this works. Everyone had to have MyChart, the patient portal access. which does limit some of the population. That's about 80% of our adult population has the portal access, but the people who don't are different than those who do. The path to implementation changed a lot. We also saw a lot of almost competing quality improvement. So they would do a new quality improvement and sometimes include coach and sometimes not. And I think that's the adaptability you have to have. However, and I'll show you this to finish, the usability is excellent of the tool. And the information that comes from it is really great. So here's an example of usability that we gave to patients using this usability tool called UTOT. And these are the kind of example questions. Is it easy to learn? Is it easy to use? And is a good idea? And mostly, actually, these are quite high scores at both 2 and 6 months. They're out of 10. And, these are scores quite high. One thing we did see is that there was a change by 6 months in terms of use of coach providing them more comprehensive care service. So really, once people started to learn how to interact with coach and send messages back to the clinic, structured messages, and figure out how to connect to the clinic, they actually felt like their service was better. The tool itself was sort of wrapping around a little bit. That's partially because it gives so much information to the care team. It's actually much easier to take action for them. The other parts that we saw is that people really found it pretty useful and felt confident in its effect, and it didn't lower personal contact anyway. They actually thought that it really helped them feel as connected, if not a little bit more than before. And then over time, we also increased the technical assistance that was provided, which was a lesson because we learned a lot about changes and problems and examples that people had, and we're able to change the application to be clearer about that. So to finalize, we're not yet done with the trial, so we're crossing our fingers that we feel very optimistic. People are really wildly enthusiastic about it. It is standards-based and open source, so it's very available now. That's where it is. You can download it. Implementing it in a site takes some time. It's not free like in, free candy that's handed out. It's free like in puppies. You got to take care of it, and we're open to collaboration with you. There is a lot of work to understand implementation strategies. However, for Epic and Cerner, which are 2 largest EHRs in the country and the ones we've implemented, we know a lot about how it can work and can help other sites through that. So again, I just wanted to thank our team. Here's my contact information, and thank AHRQ for the funding and the support over time, and I will pass it back.
All right, awesome. Thank you so much, Dr. Dorr. And again, I want to give a big thanks to Dr. Leung as well for what I thought was some pretty informative presentations for all of us today. And just as a reminder, if you have any questions for either presentation, please go ahead and submit those in our Q&A question box you have there as part of WebEx in the lower right-hand corner, I believe, is where you'll find that. And what I'm going to do is do a little bit of kind of triaging of different questions. And here we go. Here's just another slide to show folks where the Q&A box is and what you need to do in order to go through that. I'm going to start off with just a couple of kind of starter questions here. And I'll start with Dr. Leung. Dr. Leung, what usability challenges, if any, were identified during pilot testing, especially for families with limited digital literacy or internet access? And Dr. Leung, you might be on mute.
Thanks, Kevin. Sorry about that.
Yeah, no worries.
In terms of the usability challenges, it actually really was creating accounts, I will say, was one of the main challenges. And we created a tutorial to guide participants through that, in addition to walking them through and enrolling them during our enrollment process or the testing process. We actually walked them through the creation of the accounts. That was probably, interestingly enough, one of the biggest challenges. Navigating the tool, there certainly were some challenges in terms of completing some of the tasks, but we had done our best to simplify the tool and created a dashboard that was, uh, we thought, easy enough for the children to be able to navigate through. And the parent piece was a one-page newsletter that they could click on different sections that would then pull up a recipe or a fun fact or a health tip. So one of the biggest challenges actually was just creating an account.
Okay. Could certainly, see that. I think too, thinking to, probably Dr. Dorr's presentation and looking at, for particularly, the kind of patient population with those being older adults may also possibly see kind of maybe similar um, uh, experiences of those who maybe, first time needing to go in and either create an account for, their patient portal or being able to go in and, kind of how do you go in and utilize the patient portal. David, is that a fair reflection based on your
Yeah, so
experience?
what's interesting about ours, right? So to get enrolled and to get the order, the standard order even from our EHR, you have to have a patient portal account already, otherwise it
Okay.
says don't do this. But so the 20% of people who don't have that are clearly different. We actually run some numbers on them. They tend to speak a language other than English. They do tend to be older. But what we did learn is that that's not nearly enough, that there's some threshold of use of the patient portal where people really are much better at using a tool like this. And somebody asked, I see, like, is it integrated? It looks like almost like it's in the patient portal, like you log in and you can click a message or you can get a link and then you log into the patient portal. And so it's very seamless with that. And all the information goes back into the patient portal. So that lowered the complexity, but there were still unusual problems that people had. They had to create a connection to their blood pressure monitor through an app run by them, because that's how that worked, and then they had to connect that up, and people struggle with that. So we tried to lower those barriers, but we still needed to do a lot
Yeah.
of support for people, to be honest. And we were able mostly to get through it. What we've changed now is we really offer to meet in person much more. I think maybe it's in the two, to just to see what's feasible, because sometimes people just struggled and then they dropped out because they just couldn't figure out how to make it work.
Yeah. And now, maybe I got a question here. Someone would like you to comment on how parents are influenced by their child's use of these materials. And I know you had mentioned previously, before you got started, you kind of have like the child arm, and then you're also doing work on the parent arm, which you were not talking about as much today. And if you might be able to comment on the intersection there before those two.
Yep, sure. So the parent piece, actually, it is a small, dare I say, a smaller component, because really the focus was developing this comic tool for children. But we, of course, realized the important role that parents play, and so we had put together a parent piece that has weekly newsletters, which includes recipes and resources and coupons, and recommendations of health events in their local area. On top of that, the parents also have a weekly goal setting and assessment activity as well. And the goals that they get to choose from are reinforcing the messages their child is receiving. So this is an R01, and what I wanted to point out is that we developed a prototype with an R21 study that was funded by AHRQ, and this R01 grant has allowed us to adapt and extend this tool. And during our usability testing and formative research, when we were developing this prototype, we had wanted to see how we could integrate a parent component and a child component, and we thought maybe there could be a communication portal with the parent and child. And as we are conducting formative research, talking with our intended users, with our target population being pre-adolescents, they didn't want anything to do with having to communicate around healthy eating with their parent through a portal, because they are already engaging with their parents in different ways. And they wanted this to be kind of their own tool that they could engage with on their own on their own schedule, so to speak, to have that flexibility and have that independence. So we are reinforcing the messages, and the parents are able to have access to the tool. And we are providing them tips and opportunities to be able to have conversations around healthy eating with their child. But we decided to kind of take a step back and encourage interaction around healthy eating in other ways, as opposed to bringing them together within this tool, if that makes sense.
Yeah, thank you. And I'm going to do just because you mentioned engagement here, one quick follow-on question for you, and then I'll turn it back over for a couple questions for Dr. Dorr. Was someone had asked, kind of what kind of measures or instruments did you use to assess engagement, and which dimensions of engagement did you measure?
Yep. So these are results from usability testing, but we just launched our randomized control trial, and we do have various usage measures that we are collecting. And click tracking is one of them. We want to know in terms of actually how many weeks across this 12-week intervention that the children are engaging with the tool, how much of the comics the children are actually reading, which chapters they're reading, how many pages they actually are going through. We are also monitoring in terms of weekly goal setting. Are they actually selecting goals on a weekly basis? Are they actually assessing them each week as well? We are also monitoring amount of time that the children are engaging with the tool as well, in addition to the parents. So we are collecting usage metrics as well for the parents, but those are just some of the usage metrics that we're utilizing.
All right, thank you. And I'm going to now segue to Dr. Dorr. Kind of a similar question that we have here in the Q&A, which is, can you talk a bit about how long patients stayed in the study, and then what strategies did you use to sustain their engagement in the project?
Yeah, that's a great question. Since it was a pragmatic trial, we were trying to carefully balance, what would be offered in routine care. And so for engagement in the project, there's some good evidence that, if you're going to get your blood pressure controlled and in a sustained manner, it usually happens in the first month or two. The Inhofer and Kerr wrote some papers about this. So we really made a short-term goal of 2 months for trying to see if they had gone through, enough cycles to see changes. But the trial ends for them at 6 months. So there's a 2-month and 6-month survey. And we actually don't expect engagement past blood pressure control to some extent. So that's a really tricky part of our study. And in fact, we're designing the analysis now because we're almost fully recruited. And I basically said, well, some patients come in and they measure their blood pressure 6 or 12 times and it's controlled because it was white coat hypertension. And that's all we want to do, is reassure them. So that's enough engagement. We actually tell them, hey, you did great. And the messages say you met the guideline, you're good. And then pass them back to the team. But we did have multiple messages the first week. I think they're at 0, 3, and 7 days, and then at 2 weeks. To only for the intervention group to basically offer gentle prompts for them to remember to get in and check it. And we tried to tie that to what they had done again. So if they'd been measuring their blood pressures already, then we just said, great job. But if not, then we asked them to do that and also did some checking for adverse events overall. So we tried to make it lightweight and not a lot of pop-up decision support kind of elements, but we did, because people don't think about this, we tried to get them into a pattern early of checking their blood pressure.
All right, thanks. And then another kind of kind of keep piggybacking on some of these questions here is not just engagement from, those who, are measuring their blood pressure at home and going through the app, but also, being able to engage. You have a question here, and we certainly, hear this at ARC. We tend to fund a lot of studies to academic medical research centers, though, who do go out and work with other clinics that may be not atypical kind of associated research clinical environment. And, we just have a question here if you wanted to comment on kind of maybe provider adoption or engagement in these kind of clinical environments that may not always be associated with, kind of an academic medical research center or such.
Yeah, this is important question, and we actually have quite a surprising diversity of clinics, because here in Oregon, we actually have affiliate hospitals that they're very standard sort of community-based hospitals, small to moderate size. And the clinic that we had there actually did not refer initially a whole lot. We also have a federally qualified health center that we added on. And they started to refer a lot early. A lot of this, there's a lot of implementation science and engagement. And I work with a group called R.D.N here that's focused on rural practices. And, one of the crucial things is a clinic champion, who can be anyone, but is like, yeah, I want this to happen. And so some of the success strategies for the different clinics, no matter what they were that kind of champion who was willing to basically say, oh, hey, you didn't respond to our referral. Are you interested? Because you told your provider you were. Like, they did a lot of that themselves because they really wanted to get their patient's blood pressure controlled. So physician champion, or actually care team champion, because it's not always the physician, was crucial for this. And we see this at our other sites too, that in Missouri, it's pretty rural Missouri, we have like 11 clinics. And as we give attention to the different clinics and work with them, we really see a lot of differences in what they want to do. And so we try and change our messaging for them so that they can adapt it and adopt it in their own way.
All right, awesome. Thank you. May, I'm going to ask a couple of questions here directed your way. And one of those is, as you've been working, on this project here, and you mentioned earlier, kind of had an earlier ARC grant, and it's kind of helped lead into now you're able to kind of do a randomized control trial with this work. And as a part of this, are you have any current or will maybe seeking any type of partnerships now, or maybe in the future that might be related to, public health departments, school districts, or healthcare systems to maybe support future dissemination, of the work, especially if you can find out, that this is certainly maybe have an impact on that, final kind of outcomes and helping incorporate behavior change.
Yep, absolutely. And so my community collaborators, Children's Aid, in this R01 and also with the R21 project that I was funded to do to develop the prototype, of this digital tool. And they are the largest and oldest child-focused nonprofit in New York City. And so we are actually recruiting through their community-based clinics, and ultimately we want to see how a tool like this could be integrated and institutionalized into those settings. That's aim four, basically, of this R01. Really focusing on ultimately how are we able to utilize this tool out there in the real world. And so, yes, we are currently conducting a full-scale RCT to test its effectiveness, but I do have an implementation focused aim, where we are looking to see how actually this can be utilized in a real world setting of the clinic. But on top of that, this is the kind of tool that I see could be adapted in other settings, like you had suggested, potentially after school programs or schools as well. And so that's a consideration for the future. But right now, we want to think through in terms of how it can be integrated and utilized. Yep, in a clinic setting.
All right, terrific. Dr. Dorr, certainly here, again, as I mentioned, here at AHRQ, and we've done a lot of work to support CDS, or also known as clinical decision support projects here for many, many years. And, one of the key things, and, important to sometimes learn too, not only does it work, but also what maybe continue to be gaps or barriers, challenges that might prevent, clinical decision support from being, maybe more widely adopted, especially patient-facing clinical decision support, which we at digital.arc.gov, people more interested in that type of concept of patient-centered clinical decision support can go read more. But as it relates to Coach, and how is your project kind of working to help address some of these issues for adoption?
Yeah, so it's a really interesting topic because we actually had a reviewer on one of our papers tell us there's no such thing as patient-centered, patient-facing clinical decision support. It's like self-management support, which I don't agree with. I think that really focusing guideline recommendations as part of an education and counseling and engagement strategy for patients is really important for us. And there were different barriers at each site. Each site had to say, yes, I think this is safe and effective and appropriate and aligns with our values. So that's why we work so hard on the language and the connections. I see somebody else wrote about sort of the safety elements. The system does a much better job in some ways of identifying, because people are normally just said, go get a blood pressure cuff and monitor this at home by yourself with nothing, right? So having these tools to guide people and support them and engage them is really important if it's understandable and if it reduces worry, which we actually ask about very expressly, how people feel about their blood pressure through some questions. So that was a big difference. FHIR really helps a lot in terms of getting the data we need, and then the Smart on FHIR and the standards, especially with advancing USCDI, the core data interoperability measures, we know more what we're going to get. But I will be honest that the ecosystem for Smart on FHIR apps to be patient facing is really variable. And a lot of sites don't have the technological governance infrastructure to really approve them and worry about exchanging this information with patients. So one of the things we had to do, like any app does, is do a terms as they were engaging with the system, and our privacy policy had to be written out very specifically, and that's just a lot of work to sort of get that language right and make it good. But I think it's gotten better and easier over time, especially as we're able to show a lot of people want to use devices to connect their record and these apps. So with 21st Century Cures, we've used the fact that people should be able to get access to these data without special effort as well. And why not give it to them in a way that they could better understand it or engages them?
Yeah, absolutely. And one of again for the individuals who we still have, here, listening in, and I keep plugging it, and I will continue to do so, is our digital.arc.gov website, because if you're very interested in, for instance, in both of the work from today's presenters, we have a fairly useful uh, uh, project database where you can go in and find a lot of information similar around people doing kind of either similar work, but maybe on different, disease states or types. Um, if you're curious to kind of get a, kind of a better grasp of, what are kind of the different things that are out there and how are different researchers and individuals kind of trying to tackle some of these key challenges that you see. And so, I'll put kind of just an additional plug in there before I kind of go in, I think, to kind of round out our questions for today's, webinar. And I think for me, the most important thing is, obviously, we'll start with Meme, is, talking about, yes, you're in, you got to kind of wait and see here with, what's going to happen as part of the randomized control trial and that. But, if you want to speculate here a little bit about, kind of those possible next steps, and, of course, I'll throw it out there just because, certainly it's talked about a lot. We're seeing it more integrated is, how can things perhaps, in a comic book now, maybe more interactive, or using generative, AI and chatbots and, kind of these things, might be looking ahead here towards, the future, or improved ways to, iterate on some of these interventions.
Yep, that's a really good question, Kevin. And in obviously, engagement is the primary focus to um, to ultimately lead to some type of behavioral change or health impact. And so we are really focused on making the comic relevant, useful, and fun for our intended population, because talking about healthy eating is certainly not a very interesting and so to speak cool topic for children between the ages of 9 and 12. And one of the things I will say, with our R21, we did conduct a pilot RCT, and we did see that there was engagement to some extent, but that, like any other digital tool, that there was a consistent decline as the weeks went on. And this was only a 6-week intervention. And so we are in the process, well, actually with this updated or refined tool, we have incorporated some other components to hopefully enhance engagement. That we are embedding some gamified components, and the children can earn badges and coins, which they can then utilize to earn these different components of a garden that they ultimately get to build at the end of the 12-week intervention. We have incorporated trivia questions to enhance engagement, and if they answer the trivia questions correctly, they get to earn additional badges, which then will further populate this garden for them at the end of the 12-week comic intervention. Another piece that we would like to build out, which we are currently seeking funding for, is a choose your own adventure piece to this comic. So really empowering the readers to decide actually what happens to the main character and how the choices and decisions that they make will either lead to more positive health outcomes or less positive health outcomes. So those are just a couple of the things that we've added or are thinking of adding in future iterations. Certainly the AI piece and perhaps including a chatbot, it's a consideration. We haven't thought that out in great detail yet, but it's certainly something that we could utilize moving forward to tailor the messaging more for each child.
Awesome, thank you. And Dr. Dorr, kind of, same question to you, right? As going and implementing, CDS tools like Coach, and continue to maybe iterate and kind of expand on this work, or looking at any other particular, I'll call it low hanging fruit, areas or good use cases to maybe replicate the successes of this, and again, that extra little sprinkle of at the end of when you're talking about patient engagement and trying to help foster workflows between clinicians and patients, perhaps the use of AI-based tools or processes to facilitate that.
Yes, I mean, I'm chair of AI governance at OHSU, and one of our current things we've been talking about are conversational agents with patients more directly, to sort of talk through these issues. They're very interesting. I wouldn't say we're all the way there. Auto generation of messages that are more clear would have helped us a lot as we created Coach, um, so that we could, alter the language, present it different ways. Even in some cases, people can get different languages, although that's not approved for clinical care yet, where I am. But so I do see a lot that LLMs can do. The other thing they can do really well is summarization. So they could, help identify the core information that should be presented back. For instance, they could write the messages back to the providers for the patients to make sure what they include is appropriate, and then the patients could just edit that. So there's lots there. I would say, a deterministic sort of clinical decision a support approach is still appropriate here, like the blood pressure graph over time is the blood pressure graph over time. And, maybe if we build better annotation tools into that so that they can be flagged automatically for what was going on, for interpretation, and the summarization, I think would really enhance things. For us, the broader spread we're looking at are, we wrote a grant with community pharmacies that we think there's a lot here that they could do. They're really interested in blood pressure management, or blood pressure monitoring, not management as much. And then people who are pregnant, adapting the tool so that it's used to monitor high blood pressure in that group is a particularly useful use case that my colleague, Dr. Canfield's working on. So I think there's a lot of ways to spread this. It's very popular, and connecting an LLM could make a lot of sense. We really have to deal with those ethical issues around hallucinations and clarity.
Yeah, absolutely. And again, those are a lot of those are questions that us at the Digital Healthcare Research Program are also actively asking our researchers, and having people do research projects that are looking at those kind of key critical aspects, to ensure that things are appropriate, and watching ensuring that quality is maintained, patient safety, obviously, and other issues. So with about five, I want to say we have about 5 minutes left, since we weren't able to have Dr. Schoenthaler join us today, but I've seen a couple questions come up, asking about the kind of database I mentioned. I keep saying digital.arc.gov. And so I'm actually going to share my screen very briefly, just so that way people hopefully can, at least those who are joining us, kind of see, and I'll give you a quick little tour of our DHR's website. So this is it up here, digital.arc.gov. And I mentioned you can search for our projects. In fact, you can search for Dr. Dorr's project as well as Dr. Leung's project in here. And you would go to funded projects. You can search funded projects. And over here, you'll see, a lot of different kind of keywords and things based off, is it the technology type, medical condition, type of care. For here, I'll just give a demonstration here. So PI is Dr. Schoenthaler. And if I scroll all the way down here, you can see all the different folks, who we've been very fortunate to fund across many years. Is you'll come across her project right here, and you'll get a project description, as well as for all these, publications. So we try to update this as timely as possible as research projects go forward and they, get peer reviewed and they publish. We do our best to kind of update this so that way people can kind of follow along with ARC specific, funded work. So I hope that this may be helpful to some of those in our audience who might be a little bit more curious about, the work we do, as well as finding out more information about our presenters and past presenters. So with that, I'm going to stop sharing, and I'll get to the part I think a lot of people also are, hoping or want to make sure we get to is obtaining your CME, CE credits. And so again, what we got here, we got the URL shown on this slide. And so you'll select today's webinar, which will be indicated by date and title to claim your credits. And you have 14 days to claim your continuing education credits. And so again, upon exiting today's webinar, ARC is also fielding a brief evaluation. We hope that you'll complete this survey to share your feedback with us. One of the other things we do is we look at all the questions that have been, kind of entered, and we'll do our best to answer those, especially if there's some that we might not have, gotten to fully. And we'll have those as part of materials once we're ready to post this. So again, I just want to really thank our presenters today, and I hope everyone has a great rest of your day. Thanks.